Welcome to Health Fix Series number 3. This is actually part 2. And if you missed part 1, you really got to have it, check it out. It's on YouTube. Go ahead and see it. Great panelists talking about the state of Canadian healthcare and innovation involved in it. Well, today we're going to do more of that, but we're going to look at the future. And to do that, by the way, my name is Mike Campbell, and to do that, we've got 3 expert panelists with us. Looking forward to having a chat with Dr. Robert Woolard. He's Professor Emeritus of Family Practices at UBC. I've got Dr. Brian Day. Brian's got a long record because he's been past president of the Canadian Medical Association. He's been past president of the Arthroscopic Association of North America, honorary associate professor at UBC. Lots of things. I've also got with me, and this is where the rubber hits the road, is people who do something, people from the community step up and do something about some of the challenges. Well, Craig Mearns has done exactly that. I'll talk more with Craig in just a minute. But let's start right now with Dr. Day and talk about, first of all, is he optimistic about there can be change within the system?
Well, as you've alluded to before, Michael, nothing's changed in the last 30 years or 20 years since you did your last programs, and the outlook, if governments don't do something, is worsening, change for the worse, because we now have my age group starting to hit the health system like it's never hit it before. We have fixed budgets on healthcare. We have young people who are being forced into massive debt to look after their parents and their grandparents as they and we're victims of our own success in many ways, because our technology has gotten to the point now where we can do a lot more in terms of medicine and surgery than we ever could in the past. So I am not optimistic. I think that as the recent BC appeal court said, that the system appears to be headed for an implosion. And I think they're not right on everything, but I think they're right on that.
Dr. Woolard, what about a perspective about technology making a dent, at least in some of these challenges?
Technology is a double-edged sword in the sense that it is taking up an increasing amount of the budget. It is distracting from the relationships that are central to good health and good health care moving forward. And so a significant portion of the technology that's been put into the system is not particularly effective in changing things. And I don't share Brian's cynicism about the system not having changed over the last 20 years. It has changed. Some of it for the better, some of it not so much for the better. And maybe that's what our conversation can be about as we move forward. But I think, and I do a lot of international work in Africa and Asia and so on, and I see societies functioning remarkably well with a fraction of our resources, with a fraction of our technology, and getting as good or better impact on the citizens of those countries. So, it's fashionable nowadays, particularly in the last while, to say the sky is falling and the resources are inadequate, et cetera, et cetera. But I think it would behoove us to recognize that to some extent we're all blind fakirs feeling the elephant, the Sufi thing, that from the position where we are, we see it as a certain way. And I think what we need to be developing, and perhaps we can demonstrate that today, is a measure of humility and a commitment to communication about how things could be improved. Because some of the improvements have been quite dramatic. And I can go into that, but I'll turn to you because I don't want to take too much time.
Well, I'm wondering about the attitude that exists to do a best practices, to look around the world. I mean, we don't rank very well when it comes to things like from referral to seeing a specialist, when we through wait times in emergency wards, all of those things, fair enough. but have we been willing to look why we're low? And there's other, well, you mentioned emerging markets, but developed nations that seem to not have some of those problems to the same degree. Are we willing to look and borrow and do best practices?
Well, I think that there's a lot of magical thinking about how things are in Germany and Spain and et cetera. And I think what we would be best advised to do, and to some extent are significantly doing it, is in fact picking and choosing what's working, why is it working, might it work here? So, there was 20 years ago, there was a big rush. Let's get a mixed system of private and public like they have in Australia. Well, the data from Australia over the last 20 years is not terribly reassuring, and in fact has shown a shift of resources from the public to the private system. And those folks who are most on the margins are in fact suffering longer waiting lists, not shorter waiting lists. So that's, one of the areas where we can look at how do we change this. And there have been, even within Canada, some interesting innovations in Alberta, in the orthopedic realm, in Richmond here, just south of the Fraser, in the orthopedic realm of getting short list, getting lists shorter, more manageable. So there have been changes, and it's just too easy to start to be dismissive that we still have problems. Of course we have problems, but if we would approach those problems with a thoughtful way, as you've implied, look at what's working in different places, and importing those innovations here. And I want to emphasize not just the technology, but the use of that technology.
Dr. Day, can you have a quick response? You've obviously been involved with private care in the country.
Well, Dr. Woolard and I go back a long time in this debate, and he's absolutely wrong about Australia. I mean, I've been to Australia. I've got friends and family in Australia. And to give you an example, so where our standards are different. Like Dr. Woolard once gave an interview to the Los Angeles Times describing a patient of his in urgent need of care who was in severe pain, and said, the system was nimble and quick because she was likely to be treated within the next 5 months, only 5 months. Well, we just have different standards. And on talking about Germany, I just had a recent visiting fellow from Germany, and in Germany, 90% of the public are covered by public insurance, the state. 10% have private insurance. They're mostly in the upper income bracket. So I asked him, I said, how long do you wait for a hip or knee replacement in the public system in Germany, when you have this private system also? He says, oh, you wait a long time. I said, well, how long would you wait for a hip or knee replacement in the public system? He says, oh, maybe 4 or 5 weeks. In the private system, you only wait 1 week. So herein lies a difference in, in terms of what we accept. And, the government of British Columbia and other governments across the country now have maximum acceptable benchmarks for thousands of procedures. And to give you an example, just one, a prostate cancer, a bladder cancer with a high risk of progression, the number treated within the maximum safe acceptable time in British Columbia is 16%. These are government figures that came out at our trial, and the government is keeping the government is keeping these figures from the public. We had to bring in witnesses to get these figures. So we are not performing well. People with cancer were being sent down from British Columbia, were being sent to a private clinic in Bellingham because we couldn't treat them in an appropriate time. So I think that we have to call a spade, and compared to other countries, we are spending more and receiving less less efficient healthcare than any country, and we're a country that doesn't even cover prescription drugs, doesn't cover an ambulance, doesn't cover dentistry in our public health system. All of the other developed countries do.
I'm wondering, though, are there innovations on the horizon that will at least address those issues? Or, Dr. Willard, you're not agreeing to that dire, but do you still see things that will improve the situation?
Absolutely. The system should be devoted, and some elements of it are devoted to continuous quality improvement. And when you attend the Quality Council of BC meetings, you can see the people that are committed to try and make it work. I'm not arguing that things are great. They aren't. We're pretty good at acute care. We're pretty lousy at long-term care. And in between there are the kinds of examples that Dr. Day indicates. And we have to do better, and I think we can do better. The issue to me is, how do we do better for everyone? Not just the wealthy, not just those who are related to the wealthy that can get outside and move things forward. But how do we do it within the system? And I was a family doc here in town until 2019 when I retired. And I had at that time relationships with the orthopedic surgeons in Richmond, because Richmond had gotten together to try and shorten their waiting list, and they did it dramatically, shortening it. And I referred my patients to Richmond rather than Vancouver because it was much more effective at getting things done. And that's what I'm talking about. I mean, we can all pick examples of where things are terrible. But, people who are well-served tend not to be out complaining. And I would be the last person to say that things are as good as they could be. They're far from as good as they could be. But the issue is not necessarily whether it's public or private. The issue really is, how do we deploy the changing technologies, the changing relationships in a way that is much more efficient? And it's been shown that we can do that in various places across the country. Well, I've just given you one in Richmond.
A couple of things come to mind is that there has been a long-term debate about two-tiered care. But we've already had an opportunity, for people who are well-to-do financially, they've always been able to take advantage of the U.S. system. And now, as Dr. Day alluded to, we have the BC government sending cancer patients to a private clinic in Bellingham. We've had a situation where, depending on what category, certainly the Prime Minister isn't waiting for the public system to see him. Military personnel has their own system, the RCMP, federal prisoners. The list is a long one, and then you have the general public. So I'm not so sure that what we're doing is preventing that sort of two-tiered approach when it's built into the system.
No, again, I want to emphasize, I'm not saying the system is working terribly well for everyone. And the fact that wealthy people can step outside the system and get care elsewhere is as it is. The issue that I think Canadians need to deal with is the issue of fairness and the issue of efficiency and continuous quality improvement. Because there's lots of examples one can find where we're letting each other down. And when we want to do that, let's take an example, actually, of appropriate technological intervention. In 2020, COVID hit. Now, we have a long-standing inequity within Canada between Indigenous populations and white populations. Years of difference in life expectancy, etc. Now, when COVID came on, the Rural Coordination Center, of which I'm one of the associate directors, established a real-time virtual service And that was developed in conjunction with the First Nations Health Authority. And so it developed almost overnight a network of care, virtual care, for folks in remote rural communities. And because the First Nations Health Authority, different than the other health authorities, emphasized the idea of wellness, emphasized the idea of equity, emphasized the idea of embracing the community in terms of developing innovations and applying them, this became remarkably successful. And what has happened in the interval is that, in fact, other rural communities became inspired by what was being achieved in the very rural communities where care was being given within the community. And instead of pulling people out of the community through virtual care, nurse practitioners, the district nurses, family docs in various areas with surgical skills, etc., were able to be directly connected with the mothership in terms of surgeons, psychiatrists, etc. And so almost overnight during the 20s, during 2020 and 21, that developed, and coincident with that was a development of a virtual Indigenous doctor of the day. I happen to have a connection with that through the college with the young physicians, young Indigenous physicians, and they take call so that it's culturally sensitive. So there's an example of how unheralded we've taken a technology which a lot of people were afraid of and thought it was second-class care, and have now brought closer to home the kind of things that we have. We worked there with the Rural Coordination Center to try and save delivery services and C-section services and surgical services in small towns throughout the province. That has all had a positive impact on not only the communities, what they're done, but the diversion of people that are not coming down to Vancouver. They're not going to necessarily for Kelowna for their surgery or for their obstetrics. So that's happening. And to me is what Canadians can be proud of and can be good at. And thinking that just by segregating off one level of care for the wealthy and another level of care for the non-wealthy is silly. The German example of is somewhat analogous to Canadian healthcare system in the sense that the public insurance is a requirement. Here we do it by tax. There they do it by a mandated demand that you have insurance. So I'm just saying that it's much more complex than we want to think about, but that complexity doesn't excuse us being less than we can be.
Well, you've reminded us also the challenge of rural versus urban healthcare too. But I want to keep going on the technology side. Craig Mearns is someone who, he's walked the walk. He's raised money, to help out doctors and get the right equipment, et cetera, at the Victoria General, Royal Jubilee. Specifically, Craig, I'm interested how you got involved with it, because you've donated significant amounts of money to give the doctors some of those tools, surgical tools.
Yeah, well, I got involved. First of all, I've been involved a long time, way back into the 90s. But most recently, I got involved with their getting money for their robot. They have the Da Vinci robot, which they've never had in Victoria before. And after following that, raising the money, I found out about that our prostate equipment for the new better service wasn't available. We didn't have it, so I said, well, okay, I'll give a matching amount for raising money for the prostate stuff, and we raised in 6 or 8 weeks. We raised another $1 million to match what I'd given, and It's been very successful. The doctors are extremely happy with it. It's actually increased. The patient output has been fantastic compared to what it used to be. The times it's more accurate. There's less blood loss. There's less invasive surgery. It's just a game changer, and the doctors are really excited. I was at a function with them not too long ago, and they were all smiling. They were all happy because they had this equipment, and it was making such a difference to the outcomes of their patients and to themselves, because the operations were so successful, and instead of a 5-day wait, they were going home in 1 day or the day of the operation, and that cuts the doctor's work way down from all the duty calls that they have to make. They don't have to make them anymore. They go home and have dinner with their family, and it's made a bit difference. But I think that the robots are the future for surgery for the most recent or the most future right now. It's the immediate future.
Well, obviously, the huge challenge, we've seen this huge population growth. We see an aging population. So obviously, when you hear that it's helped with the doctor's output, besides their quality of life and the quality of patient care directly, that is something that's certainly going to be a challenge for the system, as we go forward.
Yeah, it is. And it's anyway, I just can't thank the Hospital Foundation, the local one, because they allowed me to go and specifically focus on a specific area that I was interested in. It wasn't just giving them a bunch of money and seeing it disappear. I was involved with the doctors, and it was just a great experience. And I advise anybody else, that has some specific area that they're interested in to try and pursue that.
Well, congratulations on the progress there. Dr. Brian Day, if you had a magic wand, I know in the past we have had a chance to talk about the way they do the global budget for a hospital. In other words, there's no incentive per individual patient. Would that change the numbers that would be going through the system? It seems like the pilot project, I remember from years ago out at UBC in orthopedics did that, and other ones I'm sure. But do you see that as one of the foundational changes that you'd like to see in the system?
Yes, absolutely. Just going back quickly to the robots, I appreciate what the other guest has done there. And if you actually Google the world's first surgical robot, you'll find that it was developed in British Columbia, in Vancouver, and that myself and Jack and Jeff, an engineer, were involved in the world's first surgical robot from BC. Unfortunately, in 1983, we were too far ahead of our time. And one of our founding shareholders, Jack Poole, donated the urological robot to Vancouver General Hospital. But getting back to global budgets, one of the problems with, we are the only developed country on the planet Earth that virtually completely funds our hospitals with block funding. And the outcome of that is, I remember trying to get new technology into Vancouver General Hospital, and I got a letter back from the vice president of medical affairs saying that we decided we don't want that technology because we don't want to bring too many patients. Everyone's going to be coming and trying to get into VGH to have that procedure done here, and we don't want that. Here is the problem when you block fund a hospital with $3 billion a year, and every patient that goes that is admitted is using up the annual revenue of the hospital, using up their funds. So patients are a cost to a Canadian hospital, whereas every other developed country, a patient brings in revenue from the government. So you go for a hip replacement in Australia or in England or in Germany, in the public system, the hospital receives revenue for that patient. You go into the emergency department at an NHS hospital in Britain or equivalent in New Zealand, the hospital gets revenue for that patient. In other words, you are incentivized as a hospital administrator to treat patients. We don't have that. And absolutely that, combined with what is called a care guarantee, meaning the benchmarks I referred to earlier. If you approach those benchmarks, you should be funded to go anywhere in the world, actually, that you can get treatment right away, because it is scientifically accepted that if you exceed those benchmarks, you're at a higher risk of dying, and finally, we know in the long term, it's cheaper to treat patients quickly. It's cheaper because patients with illnesses of all kinds deteriorate if you leave them, and leaving people on wait lists is not good. And we know at least 35,000, probably double that number, die on a public wait list in Canada every year. This is unacceptable. And so I think there's a lot to be done. But the two things for the public system are a wait time guarantee and money following the patients, so that hospitals are incentivized rather than disincentivized to treat patients.
Yeah, as you say, I mean, healthcare is such a huge topic. We're talking about something with, 42 million Canadians all have an opinion as they access the system. We have a great group of professionals at all levels, in the system. But the question is, what changes need to be made in order to improve our outcomes, improve things like wait times, et cetera? Well, that's a subject that deserves a far more attention than we're able to give it now. But my thanks to the three guests for improving that and bringing us along. Many thanks.